Welcome to the deep dive. Today, we're plunging into a condition that can be, well, both puzzling and really debilitating: Thoracic Outlet Syndrome, or TOS.
Hmm.
You, our listener, shared some pretty detailed chapters from Rutherford's vascular surgery and endovascular therapy, and our mission really is to unpack those for you.
Yeah, get to the heart of it.
Exactly. We want to understand the different types of TOS, figure out what causes them, and look at how doctors actually diagnose this thing.
Absolutely. And that textbook, Rutherford's, it gives a really solid overview. It brings up something quite interesting right off the bat, actually.
Oh, yeah. What's that?
Well, the anatomy around the thoracic outlet, that space between the collarbone and the first rib, actually varies quite a bit in people.
Huh. Variations are common.
Yeah, surprisingly so. And what's really fascinating is that a lot of people walking around with these anatomical quirks, they never have any symptoms at all.
Okay, that's definitely something to keep in mind. So let's back up a bit. What is thoracic outlet syndrome, fundamentally?
Okay, so in essence, TOS happens when nerves or blood vessels, or sometimes both, get compressed in that specific area, the thoracic outlet.
Between the collarbone and the first rib, you said.
Exactly. Think of it like a narrow passageway, and things are getting squeezed as they pass through.
Right. And the book mentions it's not just one single problem. There are different types
Yeah.
based on what's being squeezed.
Precisely. It breaks down into three main types, depending on the structure under pressure. First, and this is the big one, is neurogenic TOS, or NTOS.
Neurogenic, so nerves.
Right. That's compression of the brachial plexus, that complex network of nerves running from your neck down into your arm. And the book states this accounts for like over 95% of all TOS cases.
Wow, over 95%. That's huge. What are the others then?
So the second type is venous TOS, or VTOS. This is when the subclavian vein gets compressed. Much less common, maybe 2 to 3% of cases.
Okay.
And interestingly, this one seems to affect men a bit more often than women, about a 2-to-1 ratio according to the text.
Huh, that's interesting, because you often hear TOS is generally more common in women overall.
Yeah, that's a good point. The overall numbers skew female, but for this specific venous type, it seems to lean male.
Okay. And the third type?
That's arterial TOS, or ATOS. This involves compression of the subclavian artery. It's the rarest, less than 1%, but it's generally considered the most serious because of the potential risks involved.
Right, messing with arteries sounds more immediately dangerous.
It definitely carries higher stakes, yeah.
So nerves, veins, arteries, all potentially getting squished in this thoracic outlet. To really get how that happens, we probably need to talk anatomy, right? What does that space actually look like?
Absolutely. The textbook lays out three key anatomical spots we need to know about. The first one is the scalene triangle.
A Ganglion triangle.
Yeah, it's formed by two muscles, the anterior and middle scalene muscles. Both the subclavian artery and the whole brachial plexus pass right through it.
Okay, so artery and nerves together there.
Exactly. And this is the most common spot for that brachial plexus compression in NTOS. The book also mentions things like cervical ribs. Those are extra ribs coming off the neck vertebrae, or an abnormal first rib can also narrow this space.
Got it. So the scalene triangle is key for the nerve type, NTOS. What's the next important space?
The second one is the costoclavicular space. This is mainly where the subclavian vein runs.
Ah, so this is more relevant for VTOS.
Exactly. And it's the most common site for the vein to get compressed, often by something called the costoclavicular ligament.
Okay, costoclavicular space for the vein. And there was a third area.
Yeah, the pectoralis minor space. Now, technically, this is just outside the main thoracic outlet.
Okay.
But compression there can still affect the whole bundle of nerves and vessels passing underneath the pec minor muscle. It's particularly relevant in something called pectoralis minor syndrome, or PMS.
PMS, not the usual meaning.
No, definitely not. Pectoralis minor syndrome. It can sometimes mimic TOS or even contribute to it.
So even though it's slightly outside the outlet, it's close enough to cause trouble. Does the book mention other specific nerves nearby besides the big brachial plexus?
It does briefly touch on a few others. The brachial plexus itself is formed from nerve roots C5 down to T1, but other nerves like the phrenic nerve, which controls the diaphragm, the long thoracic nerve, and the dorsal scapular nerve are also in the vicinity. Sometimes they can be involved, or at least need to be considered during diagnosis.
Right. Now, you mentioned earlier that variations in anatomy are common. What about the scalene muscles themselves? The book talks about variations there.
Yes, that's a really important point from the text. Things like the anterior scalene muscle being split, or an extra little muscle called the scalene minimus, or fibers intertwining between the muscles. These are seen pretty often, even in people without any symptoms.
So they don't directly cause TOS.
Not directly, no. They're seen more as anatomical variations that might predispose someone to developing NTOS if other factors come into play. The width of that scalene triangle itself can also vary, and a naturally narrower space could make compression more likely.
So it's like having a tighter starting point, making it easier to get squeezed later.
Pretty much. And then
Yeah.
you have the bony issues like those cervical ribs or anomalous first ribs. They seem to have a more direct connection.
These extra ribs, I think the book had some stats on how common they are.
It did cite an older study from 1939 suggesting about 0.7% of people have a cervical rib, and roughly the same percentage have an anomalous first rib. And cervical ribs seem to be more common in women, maybe a 7-to-3 ratio.
More common in women? Okay. And how do these unusual ribs cause problems?
Well, they tend to be narrower and sit higher up than a normal first rib. They compress directly on the subclavian artery, but it's actually more common for them to compress the lower part of the brachial plexus.
Nerves again?
Mostly, yes. But, and this is key, the book stresses that most people with these bony variants never develop symptoms.
Right, like the muscle variations.
Exactly. When symptoms do occur, they're usually neurogenic. And interestingly, the text notes that neck trauma, like whiplash, can sometimes be the trigger that makes symptoms appear in someone who already had one of these bony anomalies.
That makes sense. An existing tight spot gets irritated by an injury. We also mentioned the pectoralis minor muscle earlier. How does that cause compression?
So the pectoral muscle, if it gets tight or maybe enlarged from overuse, especially with lots of overhead arm movements, it can squeeze the nerves and vessels running underneath it.
Which leads to that pectoralis minor syndrome, PMS.
Correct. And the textbook points out that PMS can actually be a reason for NTOS symptoms to come back even after surgery on the thoracic outlet itself. So it's definitely something to keep an eye on.
Okay, that anatomy overview is really helpful. Let's dive deeper into the most common type now, neurogenic TOS, NTOS. What usually leads to this developing?
Well, it often starts with those predisposing factors we just talked about, the muscle variations. Maybe a narrow-scaling triangle, fibrous bands people are born with, sometimes nerve roots that sit a bit higher, or a cervical rib.
The underlying setup.
Right. But then there's usually some kind of triggering event. The book really emphasizes neck trauma, especially whiplash from car accidents, as a super common trigger.
Okay.
But repetitive stress injuries, say from work, or even just falls, can also kick things off.
So it's often that combination, the underlying anatomy plus some kind of injury or strain.
That seems to be the pattern, yes. Pathologically, what they often find is scarring or fibrosis in the scalene muscles, sometimes even changes in the muscle fiber types themselves. There's still some debate, though, about whether the first rib itself is the main culprit, or if it's more about the muscle and ligament attachments to the rib.
Interesting distinction.
Yeah, the book mentions some studies suggesting that just releasing the scalene muscles can sometimes be as effective as actually removing the first rib, which kind of points towards the muscles being key players.
That is interesting. So physiologically, what's happening after that trigger event in NTOS?
Well, if someone already has a somewhat narrow scalene triangle, trauma can cause muscle strain, then swelling, and then as it heals, scar tissue forms.
And the scar tissue is the problem.
It can be, yeah. That scar tissue can then put pressure on the brachial plexus nerves. This helps explain why patients might first have neck pain and then later develop the pain, tingling, or numbness down the arm.
Makes sense.
The book also notes that irritation of nearby sympathetic nerves can lead to things like Raynaud's phenomenon, where the fingers get cold and change color.
Right, so it's a cascade effect. Injury leads to scarring, leads to nerve pressure, maybe even affects the sympathetic system. When a doctor sees someone with possible NTOS, what history questions are crucial?
A really detailed history is key. The textbook stresses asking specifically about any past neck trauma. But you also need to know exactly where the pain is: neck, shoulder, chest. Does it radiate? Cause headaches in the back of the head?
Occipital headaches, yeah.
Exactly. And the book points out, if the symptoms are only in the forearm and hand, you might need to think more about other things like carpal tunnel or cubital tunnel syndrome.
Good point. Differentiating is important.
Definitely. They'll also ask about musculoskeletal issues, past treatments, and those symptoms like coldness or color changes, suggesting sympathetic involvement.
Okay. What about the physical exam? Are there specific tests for NTOS?
Well, the standard neurological exam can often be surprisingly pretty normal.
Really?
Yeah. So the focus tends to shift to what are called provocative maneuvers, specific tests designed to deliberately compress the outlet and see if they reproduce the patient's symptoms.
Ah, okay. Like what?
The textbook mentions several. One well-known one is the Adson test. The examiner feels the radial pulse at the wrist while moving the patient's arm into a certain position and has them turn their head and breathe in deeply. If the pulse weakens or disappears, that's considered positive.
But I feel like there's a but coming.
There is a big but, yes. The textbook makes this really clear. A significant number of completely healthy people, maybe up to 50% in some studies, will have a positive Adson test.
Wow. Okay. So a positive test doesn't really mean much on its own.
It doesn't confirm NTOS, no.
Mm.
It might raise suspicion, but you can't hang your hat on it. Maybe a negative test is slightly more useful in suggesting NTOS is less likely, but even that isn't definitive.
That's crucial context. What other maneuvers are used?
Another common one is the elevated arm stress test, or EASE test, sometimes called the Ruse test. The patient holds both arms up, abducted and externally rotated, elbows bent, like a stick-em-up position.
Got the visual.
And they rapidly open and close their hands for up to 3 minutes. If this brings on their pain or tingling and they can't finish the test, it's positive.
And is this one more reliable?
Interestingly, the book suggests a negative EASE test, meaning they can do it for 3 minutes without major symptoms, is actually pretty good at making NTOS less likely. So it's perhaps more helpful when it's negative.
Okay, good to know.
Any others?
The last one highlighted is the modified upper limb tension test, sometimes called the LV test. This involves a specific sequence of arm movements and might include tilting the head side to side.
And what makes it positive?
If the patient's typical symptoms are reproduced or significantly worsened during the test, either on the same side or the opposite side of the head tilt. The book mentions some experts feel this test is maybe the most effective one, comparing it conceptually to the straight leg raise test for sciatica.
Interesting comparison. So, several provocative tests, but none are perfect. What about more objective diagnostic tools?
Right. So often EMG, electromyography, and NCV nerve conduction velocity tests are done to check nerve function directly.
Yes, but here's the thing with NTOS. These tests are often normal, or they might show only non-specific changes.
So they don't confirm NTOS either.
Usually not. But the textbook emphasizes they're still really valuable for ruling out other things that can mimic NTOS, like carpal tunnel, cubital tunnel, or a pinched nerve in the neck, radiculopathy.
Okay, so they help narrow down the possibilities.
Exactly. And similarly, imaging like X-rays or an MRI of the cervical spine is important mainly to exclude those other potential causes of pain, like a herniated disc.
Makes sense. What about vascular tests for NTOS?
The book says things like photoplethysmography, PPG, aren't generally that helpful because you get too many false positives with the arm maneuvers. A basic arterial duplex ultrasound might occasionally show some widening of the artery after a compression point, but it's not a primary diagnostic tool for NTOS itself.
Okay, then there's something called the anterior scalene muscle block. That sounds more targeted.
It is. This involves injecting a local anesthetic, like lidocaine, right into the anterior scalene muscle, usually guided by ultrasound.
And the idea is?
The idea is, if the patient's neurological symptoms significantly improve after the block numbs that muscle, it strongly suggests that the scalene triangle is the source of the compression.
Oh, okay. That makes sense.
And the textbook authors state that they rarely proceed with surgery for NTOS unless the patient gets clear, temporary relief from this block. It seems to be a really important predictor of who might benefit from surgery.
That sounds like a key decision point. Okay, let's switch gears to venous thoracic outlet syndrome, VTOS. How does this one typically develop? Is it different from NTOS?
Yeah, the story is usually a bit different. VTOS often relates back to anatomical variations in that costoclavicular space, but it's frequently combined with repetitive overhead arm activities.
Like athletes.
Exactly. Think pitchers, swimmers, maybe weightlifters, or people whose jobs involve a lot of overhead work. The setup is that the subclavian vein is already in a tight spot near the subclavius tendon and the costoclavicular ligament.
Okay.
Then, those repetitive arm movements repeatedly traumatize the vein wall. This can lead to scarring, narrowing of the vein called stenosis, and eventually a blood clot forming, which is thrombosis.
And that clot is the main issue.
Yes, that acute clot is often what brings people in. This specific situation is sometimes called Padgett-Schroder syndrome, or effort thrombosis.
Effort thrombosis because it's related to physical activity.
Precisely. It's important to distinguish this from secondary clots caused by, say, a catheter or direct injury. There's also a related thing called McCleary syndrome, where people get similar symptoms from intermittent vein compression, but without an actual clot forming.
So repeated irritation and squeezing of the vein potentially leading to a clot. What does the pathology look like?
Well, often there are those underlying anatomical quirks, maybe variations in the nearby muscles like the scalene minimus or subclavius or ligament issues, or even subtle bony problems like old, unnoticed rib fractures or bone spurs. The vein itself shows signs of injury to its inner lining and that progressive narrowing. If it gets blocked completely and stays that way, chronic occlusion, the body tries to compensate by developing lots of extra little veins called collaterals to bypass the blockage.
Right, the body trying to find a workaround. So physiologically, what causes the symptoms people feel?
It's that repeated compression during overhead movement, causing the vein injury, inflammation, scarring, and maybe the clot. The blockage then leads to increased pressure in the veins of the arm, venous hypertension,
And that causes.
swelling and pain in the arm. Although as those collateral veins develop over time, the symptoms might actually ease up a bit as blood finds other ways out.
Who typically gets VTOS? You mentioned athletes.
Yeah, the textbook points to young, active people, often involved in those repetitive overhead sports or activities. While older studies suggested more men, the book notes more recent data shows a more even split between genders.
Okay. And what's the typical presentation? How do they show up?
Usually it's pretty sudden with an acute clot. They'll have pain, significant swelling of the whole arm, maybe prominent superficial veins you can see, and sometimes that bluish discoloration, cyanosis. Often this happens right after some intense physical activity.
Sounds quite dramatic.
It can be, yeah. And it's important to rule out other causes of arm DVT, deep vein thrombosis. Interestingly, though, the book mentions that pulmonary embolism, a clot traveling to the lungs, seems surprisingly less common with VTOS compared to leg DVTs.
Why is that?
The thinking is maybe that tight anatomical spot that causes the clot also kind of traps it, preventing it from breaking off and traveling easily. It's a bit counterintuitive, but maybe slightly reassuring.
Huh.
What would you see on a physical exam for VTOS? Arm swelling is the big one, usually the most obvious sign. You might see the bluish color, and the arm might ache, especially with use. If it's been going on longer, you might see those dilated superficial veins over the arm, chest, and neck, the collaterals. Occasionally, you can even feel a tender, rope-like structure in the armpit where the clotted vein is.
And how do you confirm the diagnosis? What tests are used?
Duplex ultrasound is really the go-to first test. It's very good high sensitivity and specificity for finding clots in the veins.
So ultrasound is key.
Definitely. The exam needs to look at the whole vein, and crucially, they should also check it with the arm in different positions, those provocative maneuvers, to look for that intermittent compression you see in McCleary syndrome.
Right, the compression without the clot.
Exactly. If the ultrasound is negative, but the doctor still strongly suspects VPOS, sometimes a venogram is done. That's an X-ray using contrast dye injected into the vein. It might be used if they're considering thrombolysis clot busting treatment.
What about MRI or CT scans for veins?
The book suggests MRV or CTV generally don't add much beyond what a good duplex ultrasound can show for VTOS. They might also test for underlying clotting disorders if the person has a personal or family history of clots.
Okay, that covers VTOS. Now for the rarest type, Arterial TOS or ATOS. What's the story here?
Right, ATOS. As the book emphasizes, it's uncommon. It's almost always linked to a bony abnormality, like a cervical rib or an anomalous first rib. Occasionally, it can happen after trauma, like a clavicle fracture that healed weirdly.
So usually a bone issue pressing on the artery?
Yes, the core problem is compression of the subclavian artery. This compression doesn't just narrow the artery stenosis, it can also cause the artery wall after compression point to weaken and bulge out, forming an aneurysm.
An aneurysm, like a weak spot ballooning out.
Exactly. And clots can form inside that aneurysm. The real danger, then, is pieces of that clot breaking off and traveling down the arm into the hand and fingers.
Emboli.
Right, causing ischemia, cutting off blood supply to the digits. That's the major risk with ATOS.
So the mechanism is compression aneurysm clot emboli.
That's the typical sequence, yes. And because of this, patients might actually be asymptomatic for a while until one of these emboli causes sudden problems in the hand.
What kind of symptoms would that cause?
Things like digital ischemia fingers suddenly becoming pale, cold, painful, maybe numb or tingly. Some patients might get arm claudication, which is pain in the arm with exercise. But interestingly, neck or shoulder pain is less common in ATOS compared to NTS.
Okay.
Clinicians need to ask about arm pain with the activity or that feeling of a dead arm. They also need to rule out other things like vasculitis. And of course, finding out if the patient knows they have a cervical rib is a big clue.
What would a doctor look for on physical exam for ATOS?
They'll definitely feel carefully above the collarbone in the supraclavicular fossa, checking for a bony cervical rib or maybe a pulsating lump, which could be the aneurysm. They'll listen with a stethoscope over the artery for a brute, that whooshing sound of turbulent blood flow, suggesting a narrowing or aneurysm. Checking blood pressure in both arms is important too. A significant difference can indicate compression.
Do those provocative maneuvers help here?
They might sometimes bring out a bruit or weaken the pulse, but like with NTOS, they aren't very specific for ATOS. The most critical part of the exam is looking very closely at the hands and fingers for any signs of those emboli causing ischemia pallor, cyanosis, slow capillary refill, maybe mottling, little pinpoint spots called petechiae, or even gangrene in severe cases.
Sounds like a very careful hand exam is crucial. How is a TOS diagnosed definitively?
Again, duplex ultrasound of the subclavian and axillary arteries is a really important first step. It can directly visualize an aneurysm, look for clots, check for turbulent flow, and measure blood flow velocities to detect narrowing.
Do they do it with arm movements too?
Yes, ideally it should be done with the patient sitting up and also during those provocative arm maneuvers to see if compression happens dynamically. A chest x-ray is also standard to look for the underlying bony cause, like a cervical rib.
Okay.
But the textbook really highlights spiral CT angiography, or CTA, as being particularly valuable here. It gives excellent detail on the relationship between the artery and the surrounding bones.
Better than regular angiography.
Often, yes, for the diagnosis itself. Conventional angiography, where they inject dye directly into the artery, is usually reserved more for planning treatment, like thrombolysis or surgery. Given the potential seriousness, the workup for suspected ATS needs to be pretty thorough.
Absolutely. Now, the book mentioned it's possible to have more than one type of TOS at the same time.
Yes, it definitely emphasizes that.
Yeah.
Because all these structures, nerves, vein, artery, are packed so closely together in the thoracic outlet, it's quite possible for more than one to be compressed simultaneously.
So someone could have, say, NTOS and VTOS.
Exactly. Or NTOS and ATOS, or even, rarely, all three. Because of this overlap, the book recommends a comprehensive evaluation. For instance, the authors mention that at their center, Johns Hopkins, they routinely do vascular duplex ultrasound on all patients presenting with primarily NTOS symptoms, specifically looking for any hidden venous or arterial compression.
And did they find overlaps?
They did. They found that about 5% of their patients who were diagnosed with NTOS also had evidence of arterial compression, ATOS.
Wow, 5% is not insignificant.
Not at all. It really drives home the need to think broadly during the diagnostic process and not just focus on the most obvious symptoms.
That really does underline the complexity. The book also talks about general challenges in diagnosing TOS and maybe some newer tests coming along, particularly for NTOS.
Yeah, it acknowledges that diagnosis isn't always straightforward. Those bony issues can be missed on basic x-rays sometimes. We've already talked about how the provocative movers aren't perfectly reliable. And the standard EMG-NCS test, while useful for ruling other things out, are often inconclusive for actually confirming NTOS.
So what's emerging?
The textbook mentions two specific things for NTOS. One is looking at the nerve conduction of a specific sensory nerve in the forearm, the medial antebrachial cutaneous nerve, or MX nerve.
Okay, what about it?
The idea is that if the signal amplitude is lower on the symptomatic side compared to the good side, or maybe if the signal latency is different, it might indicate NTOS affecting the lower part of the brachial plexus where that nerve originates. But it stresses that labs need to establish their own normal values for this.
So it's promising but needs standardization. What's the other word?
The other is MR neurography. This uses advanced MRI techniques, usually on a powerful 3 Tesla magnet, with specific sequences designed to visualize nerves in high detail.
So it can actually see the brachial plexus better.
Potentially, yes. It might be able to show subtle changes, swelling, or distortion of the plexus within the thoracic outlet that standard MRI would miss. But again, the textbook cautions that more studies are needed to really validate how useful these newer techniques are in routine clinical practice. The field is definitely still evolving.
It sounds like it. Well, we have certainly unpacked a lot about thoracic outlet syndrome, drawing heavily on Rutherford's. Maybe we should quickly recap the main takeaways.
Good idea. So we've got the 3 main types: neurogenic NTOS, the most common, affecting nerves; venous VTOS, linked often to repetitive activity and vein compression; and arterial ATOS, the rarest but most serious, involving artery compression and potential emboli.
Right. And we talked about the key anatomy, the scalene triangle, the costoclavicular space, even the pectoralis minor space, and how variations there like muscle anomalies or extra ribs can set the stage for TOS.
Exactly. We also hit on the diagnostic challenges. History is crucial. Physical exam with provocative maneuvers needs careful interpretation.
Remembering their limitations.
Right. And tests like EMG-NCS are often more about ruling other things out for NTOS. The scaling block can be really helpful for NTOS diagnosis and predicting surgical success.
And for VTOS, duplex ultrasound is key, while for ATOS, CT angiography is often very important for seeing the artery and bones.
They're crucially, remembering that these syndromes can coexist. So a thorough evaluation looking at nerves, veins, and arteries is often needed.
Absolutely. So here's a final thought to leave you, our listener, with. We heard how common some of these underlying anatomical variations actually are, things people are just born with. Given that, what other everyday things, maybe certain postures we hold or seemingly harmless activities we do repeatedly, might just be enough in someone who's already predisposed to push them over the edge into developing actual TOS symptoms?
That's a great question. It really makes you ponder that complex dance between our built-in anatomy, how we use our bodies daily, and the development of these kinds of compression issues. Definitely food for thought.
Indeed. Thanks for joining us on this deep dive.